Hello, everyone. This is André from the Mental Health, and I'm here with Tom Freeman from Bath, one of the world's experts, I would say, in cannabis, and really excited to hear him talk on this video today. You did a great talk yesterday, Tom. Tell us a little
Yeah.
bit, first of all, why you got into cannabis research in the first place.
So cannabis is one of the most widely used drugs in the world. And in fact, a third of adults in the UK have used cannabis. Yet at the same time, we lack any information about the kind of product that people are using, unlike for other regularly used drugs like alcohol, where consumers have information about the product, its likely effects, and how much they're consuming. People who use cannabis have very limited information. So I think there's a need for consumers to have that guidance. And at the same time, we've seen levels of harms related to cannabis use elevating over the years. So one of the key themes that's underpinned my research is the increase in treatment demand for cannabis use problems. We've seen this across the European Union. Cannabis now the major reason for people coming to addiction services. And this has prompted a series of studies looking at how the kind of product people are using might influence the effects they experience, as well as how we can help those who want to stop or cut down.
So, you spoke yesterday about potency and the
Yeah.
importance of increasing potency over the last few years. Tell us a little bit about that.
So potency refers to the concentration of the main active ingredient in cannabis, which is THC. And what we've seen over the years, both internationally and in the UK, is that concentrations of THC have gone up. So we've seen this with a transition to seeded herbal cannabis products, which were available several decades ago, moving towards more sensimelia, indoor grown herbal cannabis. And now concentrated extracts rising to around 80% THC when compared to around 15% for a cannabis product such as sensimelia. So huge increase in THC at the product level. So I've been interested in seeing, does the type of product that people use affect how cannabis impacts them in the long term, with a particular focus on problems, cannabis use disorder, which refers to an addiction to cannabis. And what I found in my studies over the years is that the type of product does influence the effects that people experience. Using a more potent product was related to increased problems. It's something that we found in the UK, internationally. We've also seen that as THC levels go up over time internationally, this is followed by an increase in treatment demand for cannabis problems. And we've seen this in Europe, particularly in the Netherlands, and it suggests that the type of product people use could influence the harms in a way that they can control. So the evidence-based harm reduction guidelines we have is that if you can find a cannabis product with less THC, this could reduce your risk of harms. And equally, in places where cannabis has been legalized, setting a cap on the potency, such as in Quebec, where they set a 30% limit, that's a potentially a really important way to allow people to use cannabis more safely.
That's really fascinating. You also spoke about dose and the fact that we don't necessarily know how much THC we're getting in a joint or in a particular type of cannabis that we buy.
Yeah.
Why is dose so important, and how do we measure that?
I spoke previously about potency, and that measures the concentration of THC in the product. And we can see this a little bit as analogous to alcohol, where let's say if you have a beer, which is around 4% alcohol by volume, and you could have a wine, which is 13% alcohol by volume. And all things equal, if you consume the same amount of beer, and wine's going to have a stronger effect, so it has a higher dose. But in reality, it's not the product itself that's most important. It's also about the dose consumed. And often when people consume wine, they tend to have smaller glasses than beer. So within the field of alcohol use, things have progressed. It's not just about the concentration of drug, it's also about the total dose consumed. And we have a concept that's very widely internationally endorsed called the alcohol unit. So consumers in the UK and internationally can see the amount of alcohol on the label. They can consume either within or beyond the recommended guidelines, such as 14 units per week. And this can offer them a way to have control over their alcohol use and minimize their risk of harms. So the challenge was to translate this to the cannabis field, which is why I developed a standard THC unit based on the same principle, which has the dose of the active drug, THC, in milligrams, applying to all different products. So I suggested this standard THC unit to be applied, and now it's the kind of thing we're moving forward for our research. Researchers around the world are starting to use this in their studies, and there's now pathways towards implementing this in places such as Canada, whereby when the label is on the product, saying the number of units, consumers have much better choice, and this can help them to use cannabis more safely.
And just tell me a little bit more. So, a follow-up question: why is that so important for researchers that we can standardize these measurements?
Having researched this area for the past 2 decades, what I can say is that it's a very messy field. People will refer to, you'll often hear about a glass ceiling as a metaphor. People say it's a grass ceiling. For the grass ceiling for cannabis research is that our research is limited by the very varied measures that people employ in studies. If people do measure cannabis quantity, they measure it in a variety of ways. Often they don't. It might be the frequency of use or just have you used at all. So by having a standardized measure, it means that whenever people do individual research studies, these can then be compared and contrasted. We can combine the results of individual studies in big reviews called systematic reviews and meta-analyses. This means we have better evidence about both the benefits and the harms of cannabis. Helps us to understand what people can do to make better life choices.
So we've spoken quite a bit about THC, but we've also got obviously the CBD, cannabidiol component in cannabis, and there's lots of interest in recent years about the potential therapeutic use of that. You spoke a bit about that in your talk as well. Give us a bit of an update.
So cannabidiol is the other major cannabinoid in cannabis. It's very interesting in that it doesn't produce intoxicating effects, unlike THC. And some trials have shown benefits for medical conditions such as anxiety and psychotic disorders. So huge interest in cannabidiol as a medical treatment. We were very interested in cannabidiol as a treatment for cannabis use disorder, given the lack of any available treatments, the huge number of people coming forward for treatment, and some experimental research showing that it could be a promising treatment. So we conducted the first trial of its kind, testing a range of different doses of cannabidiol. And we found, first of all, that a lower dose at 200 milligrams was not going to be an effective treatment. But when we ramped that up to 400 and 800 milligrams, we found that actually these doses did help people to reduce the amount of cannabis they were using. So essentially, there's an ingredient in cannabis which could help people who use cannabis use less. Somewhat confusing, but cannabidiol is a part that can help people cut down on their THC use. And this was an early phase trial, what's called a phase 2 trial. Early results with a small number of people. So we're now trying to test it in a larger sample in Australia, a multi-site trial underway to see whether we have really good evidence of effectiveness and safety. It's an exciting field moving forwards.
And I guess there isn't any other pharmacological treatment for cannabis use disorder, is there? So a really exciting potential development.
Yeah, that's right. At the moment, we have these huge number of young people coming forward for treatment. They're offered psychosocial interventions, which can be helpful. But there's a major issue with cannabis use disorder in that people experience withdrawal symptoms, similar to tobacco withdrawal symptoms. And anyone at home who's tried to quit tobacco use will know that withdrawal symptoms are prevalent, they're problematic. And we have medications that can help with this. So one of the most promising things about a pharmacological treatment is that it could ease those withdrawal symptoms. The time when people most likely relapse is in those early days and weeks. And then this could be a potential therapeutic option to help them remain abstinent or use less.
It's always really fascinating talking to you. Thanks very much for joining me.
Thanks very much.